CMS survey methodology. And the significant changes that the Joint Commission put in place focuses on risk levels associated with findings that are found during surveys. What does this new scoring methodology do for healthcare organizations that use the Joint Commission? First, it simplifies the survey process. It enhances the relevancy of findings that are seen during the survey, and then it increases transparency of the survey process. And if we look at the specific changes, SAFER stands for Survey Analysis for Evaluating Risk. It uses real-time on-site evaluation of deficiencies. It places each deficiency or finding within the SAFER matrix based on the likelihood of harm and the scope or prevalence of the harm. It is estimated that academic medical centers will have an increase in the findings that will be found, about 70 to 100 findings per survey. The last 10 academic medical centers that have been surveyed had conditional findings resulting in resurvey. There is also an increased focus on ambulatory clinics, environment of care, and infection control processes. So this is what the scoring tool looks like. The SAFER matrix looks at likelihood of harm and the scope. If you look at the left-hand side of your document, likelihood to harm a patient, visitor, or staff is categorized as low, meaning it's unlikely to cause any harm or it will be rare. Moderate, meaning it can be a contributing factor to harm that can cause harm. And then high could lead to harm without need for other significant circumstances or failures. On the lower end, under scope, in the yellow box, you see limited scope. When you see limited scopes, this would be a unique occurrence. And then the second, which is pattern, this shows variation in processes. The third category would be widespread, meaning it is pervasive in the organization, it's prevalent, and it shows a systemic failure that can cause majority of harm for patients, visitors, or employees. So when you start at the low limited, here the yellow square, as you move up towards the right to the high widespread, the risk of harm increases. Hence, when we attended a conference that was sponsored by the Joint Commission, they informed the group that when you look at your survey findings and you see that you have a lot of low limited and you probably have one or two here, that is actually good for the organization. If you see that you have several under moderate and then high, that shows that the organization has a lot of work to do. And when you look at this, it's an aggregate report. Gone are the days when we will be receiving a 30 to 90-page report after a finding, after a survey with the Joint Commission. This time, the experience is one where organizations can immediately see areas of risk. And of course, you have at the topmost immediate threat to life, which is synonymous to the CMS immediate jeopardy finding. So what our team did was we used the SAFER matrix, and because we wanted to get ahead of what this scoring methodology is going to do for JPS, we took the 2015 survey findings and put it in the matrix. And this is what it would look like. So if you will notice, we had several under low limited, and then low widespread, and then we had several under moderate, limited moderate, widespread moderate, and then high limited and high pattern.
And so just a couple of questions for clarification for the group. Of course, I understand everything that you're talking about. HR would fall under human resources. I mean, some of these, the MPS is nursing,
Yeah.
with some of the
Yes.
abbreviations?
Yes.
EC,
That would be environment of care, sir.
okay, all right. Okay,
And IC here at the top would be infection control.
thank you.
That would be tissue safety, sir, TS. MM would be medication management, PC would be patient care, and LS would be life safety.
So a major point to be made here, as I've been led to believe, is that the Joint Commission thing is changing rather radically here, rather broader in scope, and rather attentive to details as to follow-up and making sure that, and so we are, as we always are, early interventionist
Yes, sir.
with what we're doing now.
Our goal is continual readiness at JPS, and we really want to make sure that we are not preparing for the Joint Commission. Our goal at JPS is daily care for our patients. We want to make sure that every patient, every time, has safe outcomes, high quality of care, and that is our goal, and that is our mission at JPS.
I have a question. Have you seen the 2016 survey?
So, great question. So what we have done this year was we attended conferences that was sponsored by the Joint Commission. WANDA and 14 team members from different divisions joined us. And from January 1st, 2017, they have done a lot of surveys. And the beauty of joining that conference is it allows us to learn from the experience, the survey experience of other organizations that have been surveyed using this new methodology. For our purposes, what we have that has JPS related information would be what I have shown. And then in 2018, we will be able to see our scoring tool. Does that answer your question? That's good, yes. That's good.
It's a delayed reaction, right?
Right, yes, yeah. 3 years, yes, yes, yes.
So I do believe at one time we were talking about instantaneous survey for groups. Is that something that's still in the works, or is this what you were talking about?
So the scoring methodology is what is changing, but the survey, the tracer methodology for the Joint Commission does not change. So what that means for us as an organization is we continue our focus on ensuring that we are meeting the different elements of performance and standards that the Joint Commission requires us to make sure that our patients, employees, and visitors are safe. We have a regular monthly tracer program, and Wanda is actually going to expound more on the actions that we have been doing to date.
Okay, thank you, Mom. Just to let you know kind of how we're preparing for this, and we try to always be ready, but knowing that we do have a survey coming up, we continuously train our staff. We're incorporating Joint Commission standards into our daily huddles so that we remind them of what those standards are, so that if a surveyor walked in tomorrow, that we would be ready for that. But we are going to have in the third quarter of this calendar year a mock survey with Joint Commission Resources, which is an arm of Joint Commission which is more of an educational component of Joint Commission. There is a firewall, so they can't come in and survey us and then go back and tell the actual surveyors what they found. So they will send in a full team of surveyors that's going to come in. We're not sure when, somebody knows when, but they haven't told us. So they'll be coming in, bringing 5 or 6 surveyors. We'll be here for a whole week and looking at our entire process to show us where our gaps are, and that's going to help us make sure that, identify where we need to really do our focus so that we are prepared for the actual survey. One thing on the graph that Mona showed you that I do want to point out to you is you saw how many findings we had from the last survey. You can expect double or more the next time based on how they're surveying this time. So we will probably, I think we had about 50 findings last time. We should have, based on our size, over 100 probably. So don't be surprised by that, okay? We haven't changed what we're doing. They've changed the way they're surveying and how they're scoring us now. Ambulatory care is going to have a mock survey with Joint Commission resources coming up in August, the 1st through the 3rd. They'll be here for 3 days, doing a very focused review of ambulatory care. Our environment of care, we have an environment of care team that is very diligent and meets monthly and sometimes more often to make sure that our fiscal plant's always ready and prepared, identifying opportunities that we need to have to fix those. Infection control, we just had a couple of months ago, Joint Commission resources come in and look at our infection control practices, tell us where our gaps were there. So, because we did have some opportunities, you saw we were in that top corner. So we had a couple of gaps last time, so we wanted to make sure we had a handle on that. So they came in and looked at where we were, gave us some suggestions on some things that we need to continue to work on. And then we're constantly looking at our policies to make sure that our policies are consistent with our current practice. What Joint Commission is going to grade you on is not necessarily your policy, but are you following the policy? So not necessarily their standard, but if we have a policy that says we do this, that's what they're going to grade us on. So we have to make sure that our policies are current, up to date, and that we haven't changed something. So we are constantly working on those. And then we do tracers. Every week or so, there's a whole team that goes out and they pick a different unit or a different department. And there's representatives from around the organization, from nursing, from the environment of care, from infection control, from regulatory, patient safety. They go to every area and they take those standards and they kind of do a grade to say where those gaps are in that individual department. So then those managers can go back and work on those areas, and they have to do an action plan of what they're doing to correct those, and those come up through the chain, up to me, to other leaders to look at that, to make sure that we're ready in all areas all the time, because surveyors could show up anytime, any day, unannounced, so we try to make sure that we're ready all the time. Any questions, or?
When we've been surveyed before, one or two of the surveyors have absolutely stopped residents in the hallway and asked them about. So are the new residents being brought up? I assume they are, but.
Yeah. Thank you, Dr. Weber. My team is actually working with Dr. Tricia Elliott. We actually started, they had their orientation about a week ago, and we are working very closely with her team to make sure that our residents are educated and aware of the different standards.
That was family practice residents, that I assume, but they hit surgery residents.
Yeah, every morning,
Yeah.
we'll not every day, but we'll pick a topic and we'll see something that needs to be upgraded, changed, altered. We can go over that in detail. I mean, we meet every morning, and anything that's important will get discussed. Yeah, and the one thing we're working on now, Frank brought to our attention, is our hand washing going between rooms. We've got to do much better and let them know that they're going to be watched. And do what we can to have improvements.
Would you teach Ralph how to wash hands?
Oh, boy, we're going to tickle
Yeah,
right by that.
yeah.
But what's amazing to me is this focus more so all the time the Blue Ribbon Committee and the community and the surveyors, the ambulatory care side of what we're doing is becoming so much more focused. Yes, you got bricks and mortar in a hospital, and it's clearly been identified that there's room for growth on our ambulatory care side, and that always takes money. But the ambulatory care side, I get the idea, is going to be looked at even more closely this time than maybe in the past. So,
That is one of their focuses this time.
yes, that's what I thought. Okay?
I have
Yeah.
a quick question.
Yes, sir.
I guess my question is around, do you have enough tools to track like outbreak investigation, disease surveillance system type thing? Because these are the outcome, right, where you want to go, but do we have enough tools to do that?
We can talk about the
It's not
EPIC.
like
Yeah,
Epic.
with our Epic system,
yeah.
it automatically notifies our infection control department of any abnormal cultures, any abnormal blood reports, anything like that, that would be a potential infectious disease process. Then they can track and trend those, and they do that all the time.
Do they get database from like Epi
It
info and all
Yeah.
that stuff?
Yes.
I remember sitting in the last time they were here in this room, and it just appeared that they were just excited to be here and thought they found us a really squeaky clean institution. And I know as you said, we had about 50 things that they found. Did you look at that to see if, wow, how did we miss that? That's, those 50 items, were there items that you would have thought you would have not been, say, cited on? And then the other question I have is, the team that's going to come in and do like a pre-review, am I correct?
Yes.
Okay. Are we doing our own pre-review before that pre-review comes?
That would be our,
That's
yes,
The pre-review is us.
yes.
That is us monitoring our situation.
okay.
So we need a pre to the pre, because that's the group we're bringing in to sort of go through the process
Gotcha.
for us.
Okay.
And I think to Wanda's point, they've just changed their standards, all actually for the better. There was a time, and you board members can remember, when Joint Commission, we were in the window and everybody would have this fear kind of attitude. Oh my gosh, what's going to happen? The attitude on the floors and the attitude through this organization is significantly different. And that is, what is it that you find that we can improve to make it better for our patients? And we are very prepared. You will find, to Dr. Weber's point, you'll find people that want to talk to Joint Commission. We had, after our last survey, 3 or 4 different divisions of our nurses team frustrated that Joint Commission had not come to them, because they said, we want to talk and tell them what we've done and what our changes are. So the pre is us. And it's always alarming if somebody comes into your house and says, I want to see how you clean your house, or I want to see how clean your car is, or whatever. There is a degree of angst to any of it. But I think the attitude towards this organization, to an organization we feel is trying to help us and help our patients, is significantly different from where it used to be. And I think y'all would see the same thing, particularly in your nurses and particularly in the teams that we have. There's a much different approach.
Okay, it would be good maybe to see what those 50 items were.
No, we know what
Yes.
they were, believe me, we followed up on every one of them.
I mean, for the
some of
board,
them-
I'm saying.
Oh,
Yes,
some
we
of
can,
them
yeah.
were, things like, if a nurse did not follow up on giving a pain medication, and they find it once, it's one issue. If they find it twice, it's, it moves up that matrix scale. So it can be something as simple as that. It could be, they saw 3 different people who did not wash their hands. So those are the kind of things that will result in one of those type findings. So or not using 2 patient identifiers. So, when you have 6,500 people, sometimes there will be a gap every now and then. We try to not have those gaps, and we try to instill that in our employees all the time, but occasionally they will find something in the ceiling that, with the environment of care, a door that didn't latch exactly properly. When you have a facility of this age, especially the environmental care stuff, it can be challenging.
Also, I might, just one point of clarification. Dr. Chuck Weber and I were in a discussion, and he asked me, had I completed my class on how to wash your hands correctly? I told him no. He said he hadn't either, so we're both stuck there.
I personally like to wash my hands of the whole topic. If you pardon the reference to Pontius Pilate, yes. Okay, other questions or comments? So it's coming. Yes, ma'am, go ahead.
I have a question about the gaps. When the tracers are out and they find these gaps, how do you put those together and implement them so the team leads can take them to their staff and take care of it?
So,
Make sure I turned it on when you were done.
So we have a robust tracer program, and as Wanda pointed out earlier, it's done by different members of the team. So it's multidisciplinary. We have frontline people, clinical people who are involved in the tracers, and it's done on a regular basis, weekly, and then those findings are actually inputted into a program, into a software that is collated, and we look at trends, we look at any patterns, and we make sure that we communicate with the unit level, the operational leaders, to make sure that we follow up. And then there is a committee that we call a continual readiness committee, where we actually, that's actually attended by almost 40 team members, different leadership roles, and action items are discussed at that, and accountability measures, as Wanda said earlier, the different senior leaders that the operational leaders report up to have accountability measures, so they have to make sure that we are correcting what we have found in the tracers. Another thing that we have instituted also is at different committee levels, like the Nurse Executive Council, the COO operations meeting. We have made sure that we go to different venues, different opportunities to share findings that we are seeing. And more, we want to make sure that it is communicated in a timely manner and there is follow-up. Because when we look at it, you know, that patient could be us one day, or it could be a family member. So we want to make sure that the correction is timely so that it makes a difference.
Thank you so much,
Thank
and
you.
I appreciate what you guys are doing and where you're going with this, because this really puts JPS on the map of cleanliness and where you want to be, and I mean, I applaud you.
Thank you.
Thank you.
Appreciate it.
Well, when you get to the level of appreciating that, don't be lost on the fact that these are academic medical centers being studied. There are a lot of other medical centers around that don't define themselves as academic. So the academic people are, because of a variety of reasons, being held to the highest of standards, and then it moves from there. Very good report, ladies. Thank you. Any
Thank
other
you.
questions or comments? I think we're good.
About opioid administration, as far as what this institution does or says, or, since that's the national topic of the year.
How about opioid administration?
Yeah.
I think that the consensus is give it when it's needed and don't when it isn't. Is that right, Dr. Johnston?
Dr. Johnson, the question was.
Opioids
So
administration.
opioids and what we're doing, I know that any of our medical team can address that. I would give a preliminary answer to that it was probably 3.5 to 4 years ago that we did a survey of the amount of opiates that we were providing our patients. We found those levels to be much higher than we felt comfortable with. And quite frankly, our standards were probably where a lot of other facilities were. We just didn't feel comfortable with it. We went back and did an entire revision of pain management and tried to figure that out. There were some leadership changes. There were some new folks that came in to deal with pain management. And some of that was just a shift in people going to the private sector, and others, all positive. But I think our protocols have done quite well, and we've reduced the amount of opiates. And I know Dr. Schrader's probably got some comments from the ED.
Well, and I would just add, and really not just the ED, but there's been an effort across multiple specialties to try to look at alternatives to narcotic administration, such as our colleagues in orthopedics and anesthesia doing nerve blocks for pain control in fractures. The ED has approached and found cooperation with our nursing colleagues to give one-time dose of IV ketamine. I mean, so there are alternatives that exist that are very safe, evidence-based practices that are being pursued to help minimize the amount of narcotics we're prescribing.
Good. We had a guest speaker here a couple of months ago, and he gave a talk that just dropped everyone's jaw. And his statistics that he showed that 1 out of 10 patients who gets a surgical procedure, whatever surgical procedure, ends up addicted to a narcotic. What happens is they first they get the pain, but then they're looking for the high that they get from the opioids. And, I mean, that was just eye-opening, and had suggestions of what we can do about it. One is what we've already initiated, is limiting the amount of narcotics that we give out. And the one thing that he showed that was, I think, very important is when it's blinded, if for pain control, patients get just as much relief with 500 of Tylenol and 200 of ibuprofen taken at the same time. It's just as effective as any narcotic you can give. So what we're trying to do is give narcotics for the first couple of days, because then there's benefit from the pain relief of that. But then start limiting the narcotics that we're giving. I mean, it's a huge national issue. I think there was one bill before Congress that now that if you want to give a scheduled narcotic, you have to report it to some agency. I mean, making it harder and harder to dispense narcotics. Well, in the physiology, I've been to the meetings you guys have been to also, the physiology of this drug is such that the opioid centers in the brain are so highly suggestive that literally in 5 days, you've got a problem. So there is a focus, and I think, in answer to your question, Dr. Weber, everything we know, we're working on it pretty well. Satisfied? Can I move forward? Come forward. We're next going to the topic of recognition of our cardiology STEMI program.
Good afternoon, everyone.
Ms. Wheeler?
Okay, which,
There you go.
oh, there it is. My finger's faster than the, I'm here today with great pleasure to
Move your
announce.
mic over just a little bit, Kathleen.
I'm here today with great pleasure to announce that Cardiovascular Services has received the American Heart Association Mission Lifeline Award, Silver Plus, for the work that we've done in the past year regarding implementing specific quality improvement measures that break down system barriers. These barriers include even working with our partners in the community, such as EMS. And Dr. Rosinia wouldn't let me bring all 40 slides.
Yeah, I'm with you. Congratulations.
Oh, thank you. It's not me, it's the team. It's a very robust, multidisciplinary team. And the first slide I wanted to bring to you that shows the work that's done with the community is our first medical contact to PCI, or when we open up the lesion or the blockage in the heart. So this shows when the EMS time frame that the EMS arrives at the home to the point the patient is in the cath lab and the lesion is opened. And you'll notice that the goal nationally is 90 minutes, and after the first or second months, we have been on a tremendous downturn to about an average of 70 to 60 minutes. So that is a great a body of work with our outside vendors and all of the EMS providers in the community. A lot of work with our ED group, a lot of work with the ICU and so forth. So that shows the work that's been done by this committee. And the next slide is, I think it's me. There it is. The door to balloon time, and that again shows that our time from arrival at the ED to this cath lab and the time of opening up that lesion is far under the national minutes of 90. So this is the type of work that the committee has done and really has shown across the nation that we're the same level as many of the other facilities across the country, and we have a lot to be proud of. And that is it.
It's a feel-good story, thank you.
That is very good.
Congratulations, that is really good.
Thank you.
We've come a long way from you're going to have your heart procedure in Galveston, which I'm still old enough to remember, and I wasn't on the board then, but
Oh, yeah. If you were lucky.
if you were lucky, yeah, if you made it to there.
Well, there are two things that are critical. One is how important our cardiology team is and how far we've advanced with a real cooperative spirit here at JPS in the past 4 years, which I really appreciate. And it's phenomenal what our cardiology team has done.
They've
and-
done a lot of
And
work.
I appreciate it. They've done a lot of work in a short period of time. And to your point, when people had open hearts down in Galveston, it's a whole world of difference, and we appreciate that very much. And the fact that Frank actually realizes that 40 slides are not good is really a positive as well. So
That's
we've
a
come a long
quantum
way.
shift. Yeah, thank
Come a
you,
long way in both categories.
Frank will have a seating in his office this afternoon with cookies and punch for those who would like to see those 40.
Yeah,
And
exactly.
pictures of his last few vacations.
Yeah, we have one cookie.
And the balloon thing has come so astronomically far. I just want to praise the people because we're now so far down the road that even poor dummy ENT surgeons can use balloons with skill and acumen. Sorry, that was. Not in the heart, no, yeah. Not-
Make sure we're on the same page.
Yes, thank you. I think if there are no items to come before us, we can move to.
Yeah.
Doc-
Yeah, I just-
Dr. Rivers-Simmons?
Yeah, I just, again, I'm broken record. Just some kind of way, I think we need to make sure, especially where we are now with Blue Ribbon, as we move closer to the bond, that the community needs to know this achievement.
Oh, yeah.
I mean, outside of employees in the hospital, but community needs to know that we got this award. I mean, for me, it would be good if every community health center that we had, when we walked in there, you would see a sign that says "Best Place to Work." You know, we got that award. I just think that some kind of way we need to do that.
I agree. I totally agree. Reverend Emerson, I personally am shooting to make it a part of my goal to see that we do go out to our community before this bond election happens. And I don't care if it's the Rotarians, the Kiwanis, the Presbyterians, whatever. If we can get the word out of how this place has changed. Every time the people seem to come here, it's like, gosh, I didn't know JPS does that.
Right.
I had no idea. So we got to get the word out. Hey, point well taken.
I agree 100%. And we have all of these vision boards. Let's utilize them. You know, we have a wonderful team of video and photographers that can do an amazing presentation to let everybody know exactly what has been accomplished in the last year.
So when's the next breakfast? October? I thought that was a great thing that got the word out to the
We
community.
we'll have another one of those events that will take place again, and that will take place about the same time it took place last year. That was good, to communicate to over 500 people what we do. This year will be a bigger event. JR will continue to do her communications. We have continued to utilize both inside the hospital and outside the hospital venues and avenues to get information out the best we can. We'll continue to do that. Your point's well taken, Pastor, and Ms. Early, your point's well taken.
Just one little, little note. Last month at the Family and Patient Advisory Committee meeting, Annika, and, you know, we were all discussing the little boards in the different clinics and the information boards and how is that. Sometimes they work, sometimes the kids get them out of order or whatever. And my suggestion has always been that I like paper. I like going into an office and maybe I don't want to read a magazine or something, but I'm sitting there and all of a sudden I'll pick up a newsletter. It tells me what's going on here, that we have diabetes classes, we have this is what we've done. Because some people don't have internet, some people don't really use their phone, you know, whatever, and we need to really remember that there are still a lot of us that like paper. And a nice little newsletter just telling us, and it can be directed to the particular clinic and the overall news, and that's a good way of getting this out. what we're doing, what we hope to do. Do you have any suggestions? Ask your patients for suggestions. You know what I mean? And just, you know, and really get them involved, make them feel like this is my home, and boy, I have this little idea, and I can just come up, and don't just have the box there, just tell them, you know, what do you think about this today? Did you have everything that you need? Did you find everything and whatever? And remember a newsletter. This is really important to me. And getting out to the libraries, that's another thing. Watauga Library, which is my favorite library because they have all these British films that I love. So, but at any rate, you know, they have people coming in from the neighborhood and the community to give little speeches and have a day or something like that. And that's a good way to let community know, you know, when people are home, you know, what's going on. JPS, I didn't even know they had, you know, connection. I didn't even know they had this. And a lot of people just don't know except word of mouth. So we got to tell them.
Great idea. And I don't remember who, but someone said the idea of JPS being represented as a bridge to the future, that JPS has gone from this to that. The concept of a bridge, I thought that was a terrific idea, JR, didn't you?
I believe that was you.
Oh. That's why I thought it was such a terrific idea. At this point, we will now move to executive session. Yeah. Executive session, thank you very much.
Righty, thank you.
I'll be right back. I got